the people who have the cameras on are essentially delivering this webinar today, so big welcome to them. I'm going to take a couple minutes just to talk about Treialon Cymru and talk about its key elements and just talk about some of the upcoming webinars. So for those of you who might be unfamiliar with Treialon Cymru, this is a new initiative funded by Health and Care Research Wales that we're delivering through the Centre for Trials Research, but it's to provide opportunities for the whole of Wales for people to engage with trials. It has three key elements. You can see this on the screen. So the Research Development Programme, and this aims at increasing the number of large-scale studies that are led from Wales and that are in areas of our high priority. The Associate Membership Programme, and this is to support people who are working in health and social care in Wales to be linked with a clinical trials unit and to develop their understanding of what a CTU is and how it works and things like that. And the Stakeholder Engagement Programme. So that's to try to reach out across the whole of Wales and raise awareness of what trials are, what clinical trials units are, where they are, and how you can work with them. And we're trying to achieve that through a mixture of webinars like this, but also through some in-person regional events across Wales. There's a QR code on the screen, so if you want to find out more about Treialon Cymru, you can scan this and it'll take you to our webpage. And I'm just listing here some upcoming webinars. So the one today, which is on inclusivity in trials. There's also one on Thursday, which is joined with HDR UK, and this is about using routine data in trials. And I think that'll also be a very good one for people to join. I'm going to ask Richard, because I can see you there, if you could pop the Eventbrite link to that webinar in the chat, just so in case people haven't seen it, they can register for that as well. I'm going to stop sharing now and hand over to Dr. Vicky Shepherd, who will be starting us off.
Thanks, Dave. I'll just share my slides, which hopefully you can see there. So welcome, everybody. I'm Vicky Shepherd. I'm a Senior Research Fellow at the Centre for Trials Research, and I'm going to be kicking us off talking about inclusivity in trials, thinking about the impact that then has on people's lives and the care that they receive. Take a little look at perhaps who we might consider to be currently underserved by research and why that is, and then talk about some of the work ongoing to improve inclusivity in trials, with leading on to one example from the area of work that I lead in CTR, which is around research involving people who may have additional challenges in providing their own consent to take part in research. And then that will take us on nicely to some of the following presentations, which talk about some other aspects of inclusivity in trials. So first of all, why we think about inclusivity in trials specifically today is, of course, because clinical trials we might consider to be kind of changing practice. They're the types of research that actually generate the evidence base that then leads to knowing what treatments, services are actually effective for people. And of course, as part of that, research more broadly is essential to improving people's health and well-being, but currently not everyone has access to research studies. And without inclusion of a diverse range of research participants, it's actually quite difficult to understand how the findings from our trials and research more broadly will actually translate into the real world. And of course, many of the barriers relating to inclusion in trials are very much the same as those that impact more broadly around healthcare delivery and who that includes, and of course picks up on the idea of those wider health inequalities that many people experience. When it comes to groups that we consider to be underserved in terms of research, we might well think of those in terms of the kind of protected characteristics you might expect. So think about ethnicity, disability or age. But of course, what constitutes underserved is quite complex and quite context specific. So that might be different in different trials that are in different populations. But first of all, to kind of put a little more understanding around what the term underserved groups means. So it basically relates to populations who are represented in health research at lower levels than would be expected from population estimates. And that would also be groups that have a higher healthcare burden that isn't matched by the volume of research designed to include them. where there are important differences in how a group responds to or engages with healthcare interventions compared with other groups. And it might seem quite obvious, but the reason it's important to include underserved groups in research is because otherwise the results might not be generalisable to those groups. So when we think about the effectiveness of our interventions, but also the benefits and the risks might be different for different groups. But also that research that isn't inclusive doesn't command the confidence of healthcare professionals, of patients, of the public more broadly. But also that the opportunity to contribute to and benefit from research should be equitable across all groups. An exclusion from access to research leads to evidence-biased care, where we have more evidence for some groups in society than others, and can contribute to a widening of the health inequalities that many of these groups already experience. And as with so many things, COVID has kind of shone a real spotlight on some of the consequences of excluding some groups from research. And you can see an example there around older people, who of course COVID-19 disproportionately affected in terms of morbidity and mortality. And that some reviews done partway through the peak of the pandemic found that half of the COVID-19 trials excluded older people, and that at that point, all of the COVID-19 vaccine trials included in that review had excluded older people. And that led to claims that COVID vaccines don't work for older people. And you can see one of the press commenting on that. And also people with a learning disability who, again, disproportionately impacted by COVID-19. The mortality was up to 6 times higher for people with a learning disability than people without a learning disability. And as a consequence, they often weren't seen as a kind of high priority group in terms of receiving COVID vaccines and follow-on treatments. We also seen the same kind of issues raised around ethnic minority groups who again were disproportionately affected by COVID-19. The deaths from COVID-19 were 2 to 4 times greater than amongst people from white population. Sorry, Black people are disproportionately affected more than the white population, 3 times more likely than white patients to have lower oxygen levels that were missed by pulse oximeters. So these were the devices that are placed on a person's finger to measure their oxygen levels. They've been around since the 1970s, and we've known about the issues of them being less effective in picking up skin that's darker since about the 1980s, but still it took the COVID-19 pandemic for this to really have some awareness and the implications of that really be considered. And similarly, breastfeeding and pregnant women have been excluded, often from clinical trials, primarily due to the kind of concerns around the kind of potential risks they might be exposed to. But again, these groups are significantly impacted by COVID-19, leading to worse outcomes. But 3/4 of trials for any of the COVID-19 treatments or vaccines explicitly excluded pregnant women. And this denied them the right to have a potential benefit that might be available to other patients. And this led to concerns that the vaccine wasn't safe for these groups and led to lots of concerns from women and the healthcare professionals treating them. And why are they groups often excluded? So this kind of cartoon kind of captures, I guess, some of the issues we might think about, and that might be kind of intended factors, but also unintended factors. And I say these will be quite often unique to different populations' needs and different types of trials. This cartoon is taken from a cancer trial, for example. But you can see how the kind of exclusion criteria shown on the left there might frequently disqualify people who are perhaps older people, pregnant women, people living with obesity, people with existing or multiple long-term conditions, people with severe mental health conditions, and of course others, including the ability to speak and understand English. But it's often the more subtle factors, which you can see on the right-hand side there. So eligibility criteria that pick up on organ dysfunction or prior malignancies that often exclude people when perhaps they has little bearing on the treatment that's being studied. And of course, there are other barriers too, which don't feature explicitly in those eligibility criteria. So that might be the kind of more logistical and practical issues. So things like geography, so where clinical trials take place compared to where people are actually living, the ability to attend appointments during working hours, And of course, things around whether trial information is actually accessible to people who have perhaps additional language communication and literacy needs, or perhaps who are digitally excluded. And funders in particular are very keen on addressing the lack of inclusivity. You can see a considerable focus in this, for example, in the NIHR's Best Research for Best Health report, which has a whole section on bringing clinical need and applied research together, particularly when we think about underserved regions and communities. And if you've applied for NIHR funding recently, you'll have seen the emphasis on ensuring that research follows needs. And you can see an example there of a map, which shows on the left where clinical trial recruitment happens in Wales, and on the right where the burden of disease is higher and in comparison. For example, some illnesses and disorders are more common amongst older people who might be more likely to live in rural communities, perhaps coastal areas. But by contrast, most research takes place around major hospitals and universities. And we can see the kind of legislative drivers there as well on the right-hand side. So as part of the new incoming clinical trial regulations, the UK government are committed to ensuring that new medicines are safe and effective for the whole population, and hence play a part in reducing health disparities. And they'll be issuing guidance on diversity in trials to improve representation in and access to research. And all this will hopefully help to ensure that the findings of research reflect the prevalence and the clinical need across the whole population, and that all can benefit from new treatments. So thinking then about what we can actually do to improve inclusivity in trials. So the NIHR have led the way as part of their Include initiative in recent years, which was a project to explore how underserved populations can be better included in research. And this very much talks about the whole kind of research ecosystem. So thinking about how we can include the perspectives of underserved groups, both in establishing research priorities, funding decisions, the whole approvals processes, and in the design and delivery of research. And they've come up with this kind of roadmap that you can see pictured there, where it shows the kind of intervention points where people involved can actually consider and put in place mechanisms to address inclusivity. And they've also developed a whole suite of resources, including training that's free for everyone to access, and a whole load of other tools that can all be found on the NIHR Include website. They have proposed some questions that research teams can look at when designing inclusive research, which encourages you to think about what the characteristics and demographics are of the population your research looks to serve, how things like your inclusion and exclusion criteria will enable the study population to match this population, to think about justifying any differences where you might see that, but also thinking about how your recruitment and retention methods might better engage with underserved groups. Thinking about how then that will contribute to the evidence that your intervention is then feasible and accessible to those populations, and how the outcomes you're using have been validated and are known to be relevant to the populations that your research seeks to serve. And as part of this has led to the development of a suite of tools, which are these Include frameworks, and these are available to help researchers at the design stage of a clinical trial. They've been developed with specific populations in mind, so the ethnicity framework was the first and perhaps the most well known, but there are now kind of sister frameworks which are looking at the including people who are socioeconomically disadvantaged, who might experience impaired capacity to consent, and then more lately some research around a framework for including older people in research that's based on these frameworks. And just the last few minutes, I'm going to look at an example of an underserved group, which are adults with impaired capacity to consent, and in particular thinking about the Include framework that I've developed for this population. So when we think about this group, we might think about how groups with who experience cognitive impairment are commonly excluded from trials, even in conditions or areas where there might be high levels of cognitive impairment in the kind of clinical population. And some examples include 1 in 3 patients with a hip fracture who also have concomitant cognitive impairment. But in fact, 8 out of 10 hip fracture trials actually exclude or ignore this population. We know that 1 in 3 studies in people also exclude people with cognitive impairment. And it's not just those older populations, but there are also populations who may experience additional communication needs, where assumptions are often made around their ability to then communicate. And an example of that are around people with a learning disability. And in fact, a previous study has found that over 90% of clinical trials are designed in ways that automatically exclude people with learning disabilities from taking part. And it also impacts on emergency research as well. So we can see the impact of the consent-based recruitment bias in emergency trials. One example being Control, which was a trial looking at a treatment for hemorrhagic shock, which, because of the consent model used, actually led to an unrepresentative population being recruited, and that led to the trial being halted for a lack of efficacy. So despite kind of growing focus on some of the other groups and inclusion in research, there has been less work done on how we can include people who may have additional communication or capacity needs. Well, some of the work I've done was to explore the barriers and facilitators to research involving these groups, that found that it was very challenging, and researchers described it as being like a black box of horrendousness, and cited the need for further guidance and for evidence-based tools that will help them address inclusion of these groups. And that led to the development of the Include Impaired Capacity to Consent framework, which was released last year. And this was a project where we worked with researchers working in lots of different areas and with lots of different populations who experience impaired capacity, and also people living with capacity affecting conditions and their carers as well. And we developed the framework over 5 stages, which you can see on the screen there, with different groups being involved at different stages throughout. We also developed an implementation toolkit, which is designed to help researchers to use the Include framework we've developed. And we piloted these with workshops with 4 different trial teams who were designing trials in a range of different trial contexts. And we launched at a webinar last year that's available to watch back, and questions that were asked during the webinar and during those workshops we've collated into a frequently asked question that again forms part of the implementation toolkit. And in terms of what all that looks like, so you can see there that we have these 4 key questions, which uses the same approach as the ethnicity framework, and it encourages researchers then to work through a series of worksheets to answer some of those questions and help them think about the intervention, who it's designed for, whether people will be able to engage with it, and then crucially how the trial design might make it harder for these groups to take part in or remain in the trial. So again, that eligibility, data collection, how the results are analysed, how they're reported and disseminated. And you can see on the right hand side there some of the implementation tools that go alongside it as well. And then very briefly, these frameworks should be used as part of a collaborative process involving public involvement throughout. We think it's useful for all populations who may experience impaired capacity and for all types of studies, designed specifically for trials, but we think it's usable more broadly, but should preferably be used at the earliest opportunity and then can be revisited during the design and conduct stages. Important to pick up on how the legal frameworks apply before considering the framework questions. And again, there are tools to help people work through those. And I'll show you the website where all these can be found in just a moment. And importantly, and as with all these groups, important to set aside time to address inclusivity and then think about any additional resources which could then be included into a funding application. So just to conclude, so trials don't currently reflect the populations included in clinical practice, resulting in evidence bias and exacerbating the health inequalities. We urgently need to change the way we design and conduct health research and trials in particular. And while there are common underpinning principles to improve inclusivity in trials, also some context-specific barriers to address. But there is help out there, including training, use of the Include frameworks, and of course ensuring inclusive public involvement. And I'll end there, and you can see the website there where all these resources can be found. Thank you.
Thanks very much, Vicky. That was really fascinating and such an excellent programme of work as well. What I'll say is we've got around 15-20 minutes at the end where we'll have Q&A session. If anyone has any questions as they come along, either hold them, pop them in the chat, and we can go back to them. But yeah, so I think the next speaker is Adam. Is that right? Yeah. Would you be able to share a screen, Adam? So Adam's going to be talking about improving LGBTQ plus inclusivity in trials. So again, a particular example of inclusivity. Over to you, Adam. You're muted.
You're muted.
Okay, so I only have a single slide, which is just an overview of the project we have planned. So Vicky actually basically covered a lot of the background for me. You know, currently there is a move to make trials more inclusive because it is becoming extremely prominent that, you know, certain populations are being left out. And the populations that are usually excluded are those that tend to have a higher burden of health inequality, such as LGBTQ plus individuals. So it's really interesting as well, because when you start looking into this, you realize clinical trials lag substantially behind for inclusive ways of collecting sex, gender, and sexuality. Sex is collected in most clinical trials, but it's often used interchangeably with gender, and the terminologies are often swapped back and forth. Even though I've also just realized from a meeting I had Friday that on the government recommended one, they're also using the terms for sex as the collection points for gender. So even the UK government can't get it right, but maybe that shouldn't surprise me. So we put in a bid to extend the work that's done with the the Include frameworks to basically create an LGBTQ plus framework in the setting of the Include ones. And this one would focus then on sex, gender, and sexuality within trials and basically how to collect them. And so the first point we're going to, as well, I should say. So this project as well is a collaboration between us here in CTR with the University of Sydney, Queen's University Belfast, Health Equity, and Pride Cymru. So the first part is to develop an LGBTQ plus framework and toolkits. So we've already developed the overall framework, or like the initial draft framework. And this presents the differences between each of the areas, so sex, gender, and sexuality, and then also started looking at the measurements required for them, and provides examples then of where you might need to collect them in certain situations and how best to collect them. Because this is the biggest problem, is that if you start using words interchangeably or not providing options for people, then it will feel very exclusive and they won't then take part because they don't think they fit your criteria unless they're just being othered, which can cover a vast range of identities. So we also provide a terminology guidance which covers sex, gender, and sexuality, and so all the different identities that can encompass that, and so explicitly states what they are and how best to reference them and refer to them. Because something that came out in one of the early meetings I had was people like, oh, I don't really know what terminology to use and I don't want to be offensive, but you may end up slightly saying the wrong thing. And so I think a terminology guidance was one of the first things I was like, oh, if we develop this, it'll, you know, make people more confident in using language. And then another area is actually developing guidance for pregnancy CRFs. So this is quite an interesting one where it seems that basically if you're just biologically female but and then are not on contraception, automatically go in to get pregnancy tests before potentially entering clinical trials, when there could be a vast number of reasons you are not going to get pregnant, either sexuality or, you know, biological issues and things like that. And so already, if you're then making someone go through this process, whereas you could have early on been, you know, is pregnancy likely during the trial? Yes, no. And then they could have already not had to go through the whole process of it because they've removed themselves as that bracket. So that's also been developed as well in collaboration with Leeds University. And I think as well, Kerry has recently put out a letter to the other trials units across the UK to ask, you know, we're trying to develop this, what is best practice everywhere? So from all of the different, from the development of the framework and all the different toolkits we're putting alongside it, We will then take this to the consultation process, which will be with stakeholders. So we will identify stakeholders' views on participation within clinical trials, but then also the framework and toolkits to help refine and finalize them. Stakeholders will be a range of LGBTQ+ individuals, not just the usual suspects. We'll include various clinicians, trial managers, those who collect the various data collectors, CRMs, research nurses, and even regulators, to bring people together to kind of identify what is needed and how can it be done best. I should also say, actually, so before we even get to the consultation stage, because this is based on if the bid is approved and we get the funding, we are already taking it to SAPSI to deliver a workshop there on the framework and basically their initial ideas of what should be in it to help us inform it as well. So then after the consultation, it will be develop and disseminate. So we'll use all the data we have available to refine the framework and toolkits to provide optimum use. And then it'll be disseminating across all relevant groups with a focus towards public dissemination as well, and using our project partner Pride Cymru to assist with that level. I think, it's helping to identify, is there a barrier within the public to LGBTQ+ individuals engaging in clinical trials, and can we address that, or is it, potentially more of an intersectionality issue than just a single level issue? But then we will also be piloting workshops for delivering workshops which will deliver a kind of how-to guide on using the LGBTQ framework. And initially we'll just pilot one, and then we'll see if there is, need and interest, and we can repeat then. But also we will be focusing on incorporating the other frameworks as well to address intersectionality. And also one of the co-applicants is Heidi Green, and they have a PhD student who is actually looking exactly at this, and looking at taking all of the Include frameworks and how do you look at research from an intersectional perspective, intersectional perspective. So again, it'll be, once we finish this, we can then assist in help. How do we look at all the frameworks together to produce the best quality clinical trials that are inclusive of everyone? But yeah, that's me then.
Great. Thanks so much, Adam. Really, really interesting work again, and lots of progress that can be made, and hopefully sort of building on other best practices happening. So the next speaker is Martina. Thanks. Hi, Martina. Martina will be talking about a project that's been running through the Centre for Trials Research called Talking Trials. Is it just you speaking, Martina, or is it Nina as well?
Yeah, Nina can't be here today, unfortunately.
Okay, great.
So it's just me. Thank you.
Over to you.
Thank you. Thank you for having me present today. I appreciate it. So my name is Martina, and I lead on Talking Trials project within CTR together with Nina Jacob, who unfortunately can't be here today. This project was around participatory approaches to creating community dialogue, and is based in Riverside of Cardiff, which has got a high minority ethnic population, one of the most diverse places in Wales. Sorry, I'm just struggling with changing. Oh, there, sorry. Yeah. So the project was initially funded under a Cardiff University public involvement scheme, where we wanted to go into a local community to raise awareness of clinical trials, address concerns and worries in these communities, and get feedback on the trials we run in the CTR, and see what we can do better to be more inclusive of different communities. We held 3 workshops with our 13 co-researchers, where we explored their perceptions of clinical trials. We discussed Centre for Trials Research participant information sheets that are used to recruit participants to our studies. And we also looked at the role of research partners within the process and other ways of getting involved in research. We collaborated with an artist, educator, Catherine Lamont Robinson, who consolidated our learning into an art exhibition with featuring quotes and art pieces from the group. So these pictures there is the top one is from the festival where we where we took the exhibition to, and we had about 300 people come into our tent. And the picture at the below is a sort of preview party we had with our group of co-researchers. So what we learned from this first project was pretty much around things like trusting partnership with a community organization, third sector organization that has expertise with working with your target group as a key element in this process, because without this partnership, we wouldn't have been able to create the diverse co-researchers group that we created. Also, the art element was an essential tool for our workshops, where we initiated a discussion around the research topic. We talked about it, and then later we explored the same topic whilst creating art, and this helped the group cohesion, where everyone felt they were contributing, and it was also powerful in enabling our co-researchers to create new additional insights into the topic discussed. It also was very helpful in addressing any existing language barriers within the group. We were very keen to ensure that we were all going into this together. We participated as researchers in the arts element as well, and we clearly situated our group as co-researchers rather than it being a public consultation. This project was highly commended at the Health and Care Research Wales Awards of 2021 in the Public Involvement Award, and we received coverage in their annual report. We published the findings in the paper that is currently on the screen, which was published in Health Expectations Wiley Journal. So during the summer last year, we succeeded in gaining further funding for this work from the UKRI Rethinking Public Dialogue Fund, where we combined the public involvement nature of the project with the research question. And we have been looking where we are testing our democratic deliberation approach, combining it with participatory art approaches, and we're looking whether this can provide clinical trial units with practical recommendations to address underrepresentation of people from minority ethnic communities in clinical trials and change practices within the trials unit. So the underlying justification for the project remains the same, and Vicky talked a lot about this in her presentation, as in health research needs to address existing health inequalities by including populations facing these inequalities in research design. The setup of the phase 2 project was similar to our phase 1. We again worked in partnership with South Riverside Community Development Centre. We have 2 of their project workers part of our kind of project delivery group. We worked with the same group of co-researchers and again use art methodology as central to our approach. We also worked with a subgroup of 4 co-researchers these co-researchers developed their own sessions and presented their journeys through the project to other members of minority communities via the SRCDC's existing community groups, for example, an ESOL English class or women's chat community groups already existing in the community. So just to give you some detail around these workshops, the first 3 ones, we were kind of looking to adopt some elements of a citizen jury methodology into our workshops, and we ran 3 meetings as part of our learning stage. These were delivered by academics that have some expertise in this area. Dr. Shoba Dawson spoke about health and well-being of minority communities. How can research help people from these communities get the right help? Farzana Mohammed, she's a pharmacist, sort of linked to the Muslim Doctors Cymru group, and she delivered a presentation on what is evidence. And last but not least, Dr. Kim Smallman from CTR was looking at a research cycle and public involvement within it. So this is just a slide. It's an example of one of the community connectors sessions run by Isla. This is the digital literacy class, the picture there, and she used a metaphor of tailoring a perfect dress been similar to designing inclusive trial interventions. These community connectors sessions, they were really sort of empowering the community connectors quite a lot, because this Isla, for example, she just created her own presentation based on the content that we presented in our workshops, and she delivered this amazing thing to the class, and we were really impressed. So there's a picture of that session there. So in terms of our findings, the art methodologies helped to redress power balances, were important mechanism for communication with a diverse group of people. Just some of the quotes here. I think the way we were using art to voice our feelings, because for some people, the language barrier was huge, and then art was the one that gave us voice. The people who were reluctant to join in, but then art was so powerful, it gave them the confidence. Or another quote, and the art lets your ideas come through. It allows you to think more about the ideas you have received and helps you to think about problem solving. It helps to extend your ideas and to break out. So yeah, literally, when in 2021, when we initiated this project, I couldn't imagine how an art might work in relation to clinical trials, but now I'm completely fully converted that in those discussions, it works really well as an additional tool of inquiry, where people think about something, verbalize something, but then they do another step and they create art, and then they think about the same thing again and come up with new ideas through that art process there. Just another example of how art stimulated further debate. This is an artwork of one of our co-researchers as a co-researchers table, where it's around, like, you need to be around the table, you've got to be around the table together, and the less advantaged you are, the more you need to be there. So if you're Black, or if you're of the minorities, whatever minority you're from, if you're a woman, it's so important. We should be there from the beginning, so that women, the people of ethnic minorities, they should have a bigger role in health research. So then we had further discussions on the back of this around why these communities are not around the table and how we can change this. So at the end of the 8 workshops we ran, as I said, we had the 3 learning workshops, and then the latter 5 were used to kind of deliberate and come up with some recommendations for clinical trials unit for CTR specifically, but we are planning to present this wider to other clinical trials units. So this is the set of the recommendations as we came up with them in the group. Some of them are around organizational cultural practices, like establishing relationships with community organizations, establish a diverse community advisory panel for ongoing input into the research process. Then the next 2, 3, and 4 are around recruitment and training, where researchers need to be more culturally aware when working with communities like that require specialist knowledge. And then the 6 latter ones are around research practice, around collecting ethnicity data from participants, making sure eligibility criteria are inclusive, and around kind of the communication, where people in the group strongly preferred some kind of individualized approach to consent, rather than what we currently have, where the patient information sheet and its content is the primary kind of focus of recruitment, where it's all about us providing information rather than making sure that people actually understand what they will be taking part in. So that's pretty much it. Just briefly, if I may, our next steps. As I said, we're trying to apply for some more funding to keep this group running, hopefully establish it as a sort of ongoing community-based advisory group for researchers to come in and gain feedback into their research design. And we're also, hopefully, we will be involving them in designing some sort of interventions like information decision-making tools, etc. So, but this is where we are at the moment. Thank you very much.
No, thank you. That was really good to see. And as somebody who's benefited from meeting with this group recently to talk through a trial and a trial idea, yeah, they're a very engaged group and very knowledgeable and very sort of willing to provide their time to give their expertise. So really, really beneficial initiative.
Thank you.
Right. We're going to move on to some Q&A. So there might be some practical questions that people might have about implementation, but there might be some broader questions. And there might even be some speaker-to-speaker questions. So happy to take anything that comes up if we can use our sort of hand raising function on Teams, if that's okay. So I look in my notes and see if I've got a question. Okay, well, Kerry's got a hand up, right? Well, Kerry, ask a question first.
I was trying to help you out, Dave. So I was going to ask a question which might be a bit unfair, but for the three of you, which is, so we have quite a lot of discussions from a statistical perspective about whether early phase trials need to be as representative as late phase trials. And I wondered if you'd had any particular thoughts on that.
I'm not a statistician, but say to have input from these groups from the onset, I think it's also important in terms of the acceptability of these interventions. And I can't really answer the question you gave, but say if you're trying to trial something that can be controversial for these groups, then to have their input from the very onset of the research design can only help the research idea to catch on. But yeah, the statistic element of it, I'm not really.
That's fine.
Yeah, I could add to that, and I guess so. I'm a member of the research ethics committee as well, and we, it's not uncommon to see studies that are feasibility studies, for example, coming to us, and what often comes up is around, who's going to be included in a trial, and particularly from my own area, around people that may not be able to provide their own consent, and how the trial's designed to be inclusive. And the researchers will often say, that's too complicated, so we're not going to look at that in our feasibility study. We will include that in our main trial. And essentially, if you are looking to see whether your trial is feasible for the populations it needs to include, they need to be included at that feasibility stage. Otherwise, all you've done is demonstrate that a theoretically inclusive trial might be feasible, and all you know is that the trial you've designed is feasible. So it depends on the type of study very much, but essentially, if it is around kind of feasibility, particularly if it's about feasibility of delivering an intervention, feasibility of recruitment, looking at the consent models, looking at the information you're providing to people, then yes, it does need. It needs to be inclusive from the outset. And we often talk about the kind of blueberry muffin kind of analogy, that essentially, if you want something to be inclusive, you have to embed it from the outset. It's like a blueberry muffin. There's no good trying to poke blueberries in later on after you've baked it. They need to be there from the outset. So I would say yes.
Thank you. Right, we've got a question from Steve.
Hi, I'm based at the University of South Wales, and I work with people with learning disabilities. We conduct a lot of participatory research. I'm also involved in developing novel medical devices. I work with a team called TRAC, Teaching and Research Advisory Committee. They're people with learning disabilities from People First groups across South Wales. What I'm interested in is, how do we get involved in wider collaborations for things like trials design? It's something the team would be very much interested in doing.
So maybe I'll come first, and I guess the first thing is, you've spoken to us today, and that's an excellent place to start. We would be very keen to engage with you. It is something that, so for example, that Include framework I mentioned, we did involve people with a learning disability and family members in the design of that. And part of that is we've developed an easy read guide to using the framework, because it does need to involve groups when considering how we design a trial. But I guess a lot of this is about how we can include people with a learning disability, for example, in all the different types of research we do, as you know, as members of society in general, I guess. So perhaps we could follow it up with you after today. But yeah, really great to kind of build that connection, I think, with you.
Okay, thank you.
It's really good to hear about that link. Thanks. Right, I'm going to take a question while others are thinking. So, Martina, you mentioned a co-researcher model with Talking Trials, and I'd already noted something down on my notepad before you said that, which was about wider inclusion of underserved groups as researchers, and whether people think that that should be an important priority. And I guess if any of the approaches you're taking sort of encourage that, and if not, what approaches could be taken to encourage that?
So we did it to kind of democratize our approach, where we wanted to be around the table and we wanted to be on an equal footing with everyone. So we basically participate in the art, and we take everyone's voice as equal to anyone else's. And that, I think, the kind of the rationale behind that is around making sure that the power in the room isn't with anyone specific, and that we are all we feel all empowered to do the process in the way we want to do it. And the kind of the empowerment from the kind of reciprocity between us doing exactly what the rest of the group, it really worked with this group. And I can't say if it, you know, how it would work in other settings, but for us, the kind of reciprocity, supportiveness, all those kind of values really worked for people to create a cohesive group, really trusting, you know, happy to share really kind of sometimes very private kind of medical information with others, etc. So in that way, this model of co-production, co-researchers worked for us really well, and I would recommend it. I know it sounds kind of, say, the ethics committee, the ethics committee we approached, they questioned it, whether we are really thinking about these people being co-researchers, and I was a bit surprised with that, but then we justified it, obviously, and it was fine. But yeah, there's it's not from that I realized that it might not be a kind of common approach, but for us it worked. Hope that answers your question in some way.
Thanks, Martina. I won't. Do Adam or Vicky have anything to add to that, or should we move on to other questions? No. Okay, I think Michelle was first.
Hi, I'm Michelle. I work in the Marie Curie Research Centre. I was just wondering, how do you integrate, say, community-based public involvement people with our team of experienced public involvement who work with us on our trials and our projects? How does that work? Is that like a separate group, or do they come together?
So if this is question for me, I don't think we, so I also sit at CTR, we have the PPI hub, which is kind of basically running or overseeing our public involvement activities within the centre. I'm part of that, and I will be arranging a session of our group to come to present to PPI, to our hub, around the findings from the project. But at the moment, any of the researchers from our group would kind of, those that were interested to become involved in research as research partners, and we've had a few of these, then they would just become our regular research partners, and they would be kind of going through the same channels as any other research partners we have. But I'm not sure. So that's kind of, does that answer your question, Michelle?
Yeah, obviously.
Yeah.
Okay, so next up is Frances.
Hi, no, thanks very much for the presentations. I work with young people with sort of mental health difficulties, and I suppose I was struck by the presentations. There's quite a lot of talk about either individualised consent or, you know, consent for people with impaired capacity. And my impression, I suppose, about consent now is that these have turned into legal documents. And I suppose I just sort of wondered which I think impacts on inclusivity in research full stop. So I just wondered if people had thoughts and ideas about how we overcome that. So for instance, a trial that we're doing, you know, in conjunction with CTR, we've got a simple information sheet for younger people, but I felt like that would be useful to give to everybody actually. But I just wondered what people's thoughts were on that.
Yeah, no, I completely agree. And I guess there's a few things, aren't there, to mention. And first, you know, you're right, there's a lot of focus on written information sheets. And I think one way of understanding that is that that is all often that people can make a judgment on from a governance perspective. And so they put a lot of attention on the written information. That's all that they can kind of see in front of them. But of course, all that is embedded within the processes surrounding that, who's involved in the consent process. And so it's trying to, you know, make that clearer as well in, for example, ethics applications, that the information just forms one part of that. But you're absolutely right that making information much more accessible for everyone is important. And it's only when you turn, so we might refer to an easy read version, for example, or a plain summary of something. And it's only when you then think about how you describe the main information sheet. So if you have an accessible version, presumably the full information sheet is an inaccessible version. You know, it's that kind of concept, isn't it? But there are, you know, often from a sponsor perspective, certain parts of information that need to be included. So very much think about how you can layer the information, and you're absolutely right that having one version of information that's more cognitively accessible to younger people, perhaps supported by diagrams, by pictures, layering the kind of concepts that you're talking about, and then your full information sheet features as kind of part of that layering, but they fit together. So it's making it clear that the simplified version, the more accessible version, is as well as, not instead of. And that helps the people then recruiting participants, talking to participants, potential participants about the study, but also in terms of the, you know, the kind of governance aspects about ensuring that that full information is available somewhere, might well help. But yeah, that kind of layering of information, which we should be doing for all our studies, not just those where we might think that there are particular need to do so. Yeah, thanks. What about technical summary? Is that a accurate description, I suppose, of a full information sheet? Maybe that's a nicer way, yeah, rather than describing it as an inaccessible version. Yeah, I like that.
Yeah. Idea. Harry.
So actually, it's just a follow-on to that, because I think one of the things we did for quite a while ago, actually, for one of our trials in people with a learning disability, was because they were providing consent themselves, they had all the easy access stuff, but what we actually gave them was a sheet for them to help them to use in discussions with their carers for what questions other people might ask them. So that, you could say that kind of had technical details on it, but it was like if you get asked this question, this is the detail of it. This is it. So that was quite a different approach, I thought, but it was recognizing that they may be comfortable with their decision, but they still might get questions that they find hard to answer from other people about the fact they're taking part.
Yeah, okay, interesting.
Yeah, it's all part of that idea of supporting people to be able to access information, understand the information, make a decision for themselves, and where that's not possible, involving other people. But yeah, supported decision making. Yeah.
Great. Thanks, everyone. Okay, so I'm going to start drawing this to a close unless there's any other questions. And just wanted to start by thanking the speakers for being here and giving their time and expertise. That was really, really helpful. And even though I work with all three of them, still got me thinking about the work they're doing and how it could apply. So it was an eye-opener to me too. Thank you for that. As I mentioned at the start of the webinar, we've got another webinar happening this Thursday, which is joined with HDR UK and focuses on routine data in trials and how people can use routine data in different ways in trials. There'll be other webinars that are happening throughout the year as well. I think you'll probably have our contact details. Certainly they'll be on the Treialon Cymru website. So if you think of a topic that you don't think we're covering or you think we just need to cover, drop us a line and we can try to put something together. But yeah, so thank you, and thanks for everybody who's joined and asked questions and engaged, and we'll see you again soon.